So will be a short conversation, which really summarizes many conversations that we have taken part in and heard over the last few days. So I just want to take 1 minute to remind everyone of why we wanted to do this conference in the first place. And it really was to look across all of Partners Healthcare, see the incredible science that was occurring, and see all of the rest of what was going on in Boston and nationally, and trying to have those conversations that led somewhere between those of us in academics, those of us in industry, and investors. And I think that there are a couple of themes that I just want to highlight that we're going to talk about that have come up over the last few days. And I think the first thing just to emphasize is the diagnosis of disease and disease stages. And the fact that one can diagnose a disease doesn't necessarily tell you very much about it. And this has come up repeatedly. So if you have a patient with heart disease, they can have very early heart disease, or they can be in very severe end-stage heart failure. And the question is, how do we manage that differently? Where is early treatment? Where is its role? How do we identify those early biomarkers? And we heard about this in Alzheimer's, in multiple sclerosis, and a number of other settings. And what is the role of genetics and other approaches in trying to identify those disease stages where we all together can work toward some type of clinical effective treatment?
So I'd like to start by saying that I've been going to healthcare meetings of one kind or the other, investor meetings, specialty society meetings, industry meetings. And this is one of the most enjoyable and productive meetings I think I've attended. I think we should all acknowledge the hand of the master here, Chris Coburn. I've thought about a lot of things. I've found myself filling the book and taking notes, but in terms of summary, I'd say the following. I watched a friend die on the neurology floor at Mass General of an sudden onset of a hopeless, paralyzing disease that took him about 6 weeks to die. My daughter, as it happened, was rotating on that floor as a student. And we talked about this subsequently as she finished her medical residency and is on her way towards oncology, about the fact that she really thought neurology was interesting, but oncology you could do a lot. And so in some ways, that's a few years ago, but it probably colored my layman's experience of neurology. So one of the themes for me at this meeting is I'm feeling much more optimistic about neurology and about brain disease as a result of the things I've heard. I wrote down a few of the things that sort of made me happy or made me feel more optimistic, but a lot of them are around 2 points. One is more and more tools, and tools of all kinds. I think Dr. Gwanda's talk was rich with a lot of themes that are resonant for me, but we're seeing more and more tools of every kind, and particularly in this growing and I think lovely intersection of the somewhat previously separated tech and health worlds. Frankly, I also saw a cultural conversation that was somewhat encouraging. We have had in medical research and development a pretty atomized, reductionist culture, and again, Dr. Gwandi spoke to this, and some of that's for good reasons, some of that just is the way it was. But one of the things I've always thought it was because it lacked engineering, that people who are drawn to biology and to science of a certain kind were not that interested in engineering, or if they were, they became surgeons. And I think as we look at the opportunity to bring all these tools to bear on the patient, with the patient at the center, if we think about all the tools we can bring to bear on solving the clinical problem before us, it says to me you need a systems approach, again, resonant theme, and you need to find structures and techniques and methods of having a system, and it's an engineering discipline. And so now this collision of physics and biology, of engineering and science, which I've seen at this meeting, has made me quite encouraged, at least in cultural terms.
Yeah. I think the other thing we heard a lot about is redefining what we think about as targets. So there's always an enormous interest in the academic community on finding targets and thinking about targets. And I think there are two things that came out in that regard. Number one is not just the finding of the targets, but the finding of targets that lead to a clinically meaningful, impactful endpoint. And you know, I think we see this again and again, particularly when we're thinking about the use of biomarkers in this regard. And also, is the target something that will eliminate a disease? Will it halt progression? And what will it do in terms of the quality of life? And I think these are important areas that undoubtedly have come up that are really department or even discipline independent. So, you know, many of these themes I think we're going to be hearing about next year and the year after, even though we're talking about a number of different diseases. And these endpoints are extraordinarily important. And I was just mentioning to Duke right before this session that I'm very interested in pituitary tumors. That's what I work on. And in oncology, you have a lot of crosses between drugs used for one tumor and then they cross over into another. And I was working with a company for a number of years. They have developed what they thought was a fantastic drug for a type of cancer, and the markers showed an amazing response. And they've halted all their trials now because it turned out that although the markers responded beautifully, there was no impact at all on the patients and what the endpoints are. So I think this is a very important area that we're going to be thinking more and more about. And again, just to emphasize that our ability to do this not in isolation, and this concept of vertical versus horizontal thinking on these problems and how we want to engage everyone together, again, is really at the heart of this conference.
Yeah. So, just indulging myself slightly, I did come up with a couple of things I thought were fascinating. I love this notion of electroceuticals, and I love this notion that virtual reality can be a therapy for profound brain disease, PTSD, and so forth. But it brings me back a little bit to a third theme for me, or the issue of optimism, the issue of the need for collaboration, and that's thinking about this gap between the obvious unmet need, the gigantic unmet need in the area of brain disease. I mean, we've had many, many conversations about each of Alzheimer's and ALS and so forth, but taken as a whole, any one of those is a huge problem. Taken together, it's enormous. But there's a huge gap in sort of a sense of in the room, but in terms of public awareness, this public passion about it, and all the funding, et cetera, that would come from it. Some of that, I think, is because people have felt it was sort of hopeless. And when you don't have any hope, then you don't tend to spend a lot of money. And you heard the venture capitalists acknowledge that they have not spent a lot of money in neurology. Maybe they're starting to get a little hope, and they'll start to do that. But I think that if I would make 2 points that I've thought about the last couple of days. One is, there is hope, and if I can sort of see it as a layman, I think articulating that in ways that become more visible so that people can begin to feel like if they spend some money, there's hope. And then building on the incremental progress. There's an opportunity here to not get things perfect, but get things incrementally better. And you make incremental progress. If you can help stabilize symptoms of a patient, even though you don't know the exact biology, you can't cure the disease, I think that helps give hope, and it'll help attract funding. The other thing is, cancer has benefited from enormous public awareness and passion, and it was always thought of as cancer. Now, of course, we know it's just a whole bunch of orphan diseases, and the biology's gotten better and so forth. In a way, oddly, this has always been a more fragmented field. It wasn't brain disease, it was MS, it was Parkinson's, it was Pickett, traumatic brain injury. And I think one of the, again, it goes back to this systems notion. I think a challenge to us, to the world here, is help people understand this from a systems perspective. This is brain disease is the problem of the 21st century. Cancer was the problem of the 20th century. We're making progress. And we have to articulate it like that. And we have to find ways that fabulous groups like the ALS societies and the Alzheimer's societies, et cetera, are also animated. I mean, there is an American Cancer Society that overarches leukemia, lymphoma, and a bunch of other stuff. There is an American Heart Association that overarches a lot of stuff. And I think, again, it's an engineering problem in a way, but it's also a cultural problem. We got to think in collaborative fashion. We got to think how we can each do our part and put structures and systems in place that allow us to bring the passion to this. I'll just make one last comment and then I'm done, which is I found myself, as a result, saying, well, what could you do? All right, that sounds good. What can you do? So I'll just leave with you. I mean, what can you do? I don't know the answer. I'm thinking about it for myself. But all of you should be thinking about that.
So the last comment I'd make is just a rethinking, because this is a theme, again, of this year that will come about year after year, and that is the concept of the cost of innovation. You know, and we heard this a lot in very concrete terms. What does it cost to bring a drug to market? What is the cost to the healthcare system, and who's paying for it? And you know, I think what came out of this symposium, and it came out in multiple ways, is that you have to weigh the cost of a therapy, whether it's a therapeutic, a device, whatever it is, against the cost of disease burden to the patient, to society, to insurers. And what is that total cost really going to be? And how long does that last versus the cost of a therapy itself? And how do we factor that in as a healthcare system, as a population? And also thinking about a point that was made is the launch cost of a drug versus what it means in terms of lifetime expenses and the total cost to society. So I think that's something that's going to come up again and again. It's come up in the past. And those are some of the things that I think we will touch on year after year, which leads me into my final comment, which is, as many of you know already, next year, so 2016, the topic will be oncology. So we are going from the incredibly hard and challenging to the easier, I would say, at least by some people's thoughts. We have two fantastic co-chairs, Daniel Haber, who's director of the MGH Cancer Center, and Monica Bertinelli, who's chief of surgical oncology at Brigham. And again, I want to thank everyone, Chris and his team, for doing a fantastic job, our sponsors, the co-chairs, and all of the people who've worked on the various committees. So thank you all again, and see you hopefully all next year.